Let's begin the second part of hepatobiliary surgery in pancreatic surgery questions from eMRCS 2024. So the first question is, following an uncomplicated laparoscopic patient is found to have bile leak, eRCP is performed, leakage is noted from the cystectomy. What is appropriate? Under sphincterotomy, undertake laparotomy, T-tube, start total parenteral nutrition and keep nearby mouth, transfer patient biliary bypass, place it. So what is there after laparoscopic? There is eRCP. Leakage is noted from the cystic duct. Stent has to be placed. Stent whether it is done. Undertake laparotomy T-tube plus transbiliary stent. No. Undertake sphincterotomy and place a stent in common bile duct. A. Next is 45-year-old man presents with episode of alcoholic pancreatitis. Low. He makes slow and steady progress. Review 6 weeks after admission. Failure of diffuse fullness upper abdomen. Imaging collection of the fluid behind the stomach. So this is lesser sac, post pancreatic pseudocyst. Next question is 63-year-old man is admitted to ITU attack of severe gallstone pancreatitis. ARDS more unwell and scan is organized, demonstrate areas of necrosis. Gram negative CRP is very high. Attempt to percutaneous drainage have failed to improve the situation. So this patient will need distal pancreatic necrosotomy. Necrosis has happened. Next question is surgeon is undertaking cholecystectomy for cholecystitis secondary to gallstone. The operation is difficult and callous triangular. Unfortunately, distal aspect of the bile duct is transected. So distal is transected in most appropriate course of action. So suture is not possible. Repair the defect over T-tube. Place the drain close and discuss with hepatobiliary. So T-tube is to be done, but here option is place a drain and close the wound and discuss with hepatobiliary surgeon. Don't try to do that T-tube. Okay. "68-year-old man with type 2 diabetes, means it is oral hypoglycemic. Feature of septic shock, right abdominal tenderness, not jaundice, normal bile duct, no gallstones. This is acalculous cholecystitis. "43-year-old lady with 24-hour history of generalized right upper quadrant pain. Right upper quadrant pain, admission septic and jaundiced. Tenderness in the right upper quadrant, which is most likely cholecystitis. Cholangitis, septic is there, cholangitis. The next question is 73-year laparotomy, gallbladder ileus is identified. Gallstone ileus and gallbladder itself densely attached to duodenum. Course of action: milk the gallstone, no milking. Remove the gallstone, no from the bowel. Resect the gallbladder and close the duodenum defect transversely, no. Remove the gallstone from the small bowel and perform subtotal. Third is leave the gallbladder alone. Remove gallstone. Leave the gallbladder alone. Okay, gallbladder should not be removed. Remove the gallstone only. Remove gallstone from the small bowel and leave the gallbladder alone. In gallstone ileus, there is gallbladder alone. It should not be removed. Okay. "41-year lady, colicky right abdominal pain is identified as having gallstone or abdominal ultrasound. What is the approximate initial course of action? Colicky, gallstone, laparoscopic cholecystectomy. Okay, first initial courses you have to do LFT to rule out obstruction in the CBD. Next question is "40-year-old woman is admitted 1 day history of abdominal pain, suffered from repeated episode of colic right abdominal pain, pyrexia right upper quadrant, blood test WBC count, however fever function normal, abdominal ultrasound, multiple stones with thick gallbladder and bile duct is 4. This person will require 1 day history of abdominal pain. cholecystectomy, whether range radiological now, laparoscopic cholecystectomy. For proportion patient presenting hepatobiliary colic due to gallstone will have stones in common bile duct. How much percentage? CBD can be there in 10%. 10% of the patient can have CBD stone. 42 female present with biliary colic and investigation identified having gallstones, likely to increase risk of gallstone formation. Which of the procedures? Gastrectomy will definitely ileal resection, right? Intrahepatic circulation is reduced. 48-year-old lady admitted with attacks of biliary colic and investigation showed gallstone. Laparoscopic cholecystectomy is performed. Operation technically challenging due to large impact stone. She fails to settle, become jaundice and bile draining in the surgical. What is the word? eRCP and stenting. 53 patient attack of severe acute pancreatitis. She is managed intensive care and deteriorates, and CT scan shows extensive necrosis. They are a concern may be infected, and what correct course of action? Laparoscopy. First of all, a fine needle aspiration has to be done to find out which type of organism. Then necroscopy. Already elective cholecystectomy, attacks of recurrent cholecystectomy, microcysts are more likely to which of the following? Broken sinuses. This is the hyperplasia and herniation of epithelial cells. Asha of Roketansi. This is seen in the cholecystitis. "22 man returns to UK from holiday in India, present painless jaundice. What is the most likely? This is hepatitis A enteric. Which are the following most sensitive blood tests for acute pancreatitis? Amylase, lipase, C-peptide, trypsinogen, trypsin. Serum trypsinogen, lipase, serum lipase. Lipase is fall quickly, may rise and fall quickly and lead to false negative result. Most sensitive test is lipase, serum lipase. 34-year-old acute pancreatitis. Etiology unclear. Killers by the attacks of moderate severity Glasgow criteria. No gallstones and fluid around the pancreas, which are most appropriate management. So pancreas is there, imaging show no gallstones around the pancreas. Which are the following appropriate management? Active observation. Mnemonic for severe pancreatitis. Pancreas, PO2, age, neutrophil, calcium, raised urea, urine. This is Glasgow Ranson scoring system. "53-year referred because he was investigated with ultrasound for gallstones. Ultrasound for gallstones. Whilst a large stone was seen in the thin wall, a lesion was seen in the left lobe. The MRI has been categorized 6 cm hepatocellular adenoma. Surgical resection. 43-year male long-standing hepatitis and followed by alpha-fetoprotein is increased. Ultrasound demonstrated 2 centimeter lesion. Appropriate course of action: PET scanning, liver MRI, USG guided biopsy, liver MRI prior to resection, risk of multifocal lesion. 23-year-old lady is 23-year-old is admitted with upper cardiac pain. So examination is tender acute cholecystitis, gallbladder carcinoma. What is the most appropriate course of action? Open position, laparoscopy 3 months, 1 year. Open position, double position after 5 days, 24 hours. Mm. 34-year-old is admitted with cholangitis. Bilirubin is high, become unwell. Check serum amylase. Her amylase is elevated. Glasgow score is 3. 34 years, laparotomy, PTC, pancreatic microsotomy. Now there is cholangitis. You need to decompress it. Whether ERCP, PTC, laparotomy, pancreatic, ERCP is best. 34-year lady is undergoing 34-year cholecystectomy. Unwell father attempt to dissect the gallbladder. All are seen. Adhesions are made to dissect. What is the best? Partial cholecystectomy. Convert it to. Is there option? Perform operative cholecystectomy. '53 alcoholic develops acute pancreatitis and making slow but reasonable progress. Paratic ileus is there. CT scan demonstrates large pancreatic pseudocyst. One is no resolution. So pancreatic cysto. Elective cystogastroscopy. 56 men with jaundice. History of long alcohol use. Dense lesion lobes of the liver, alpha fetoprotein is elevated. Hepatocellular carcinoma. 42 years suffered from the hepatitis C for many years and developed cirrhosis. Ultrasound 2.5 centimeter lobe. So hepatocellular carcinoma again. 32 men suffered from Crohn's disease and for many years presents with intermittent jaundice. It is usually resolved spontaneously. Bile duct stones. 65-year-old man is admitted with cholangitis. A man demonstrated carcinoma head of the pancreas. ERC evidence surgeon made unable to cannulate. Laboratory information of hepatic angiostomy. Cholangitis is there. Percutaneous cholangiogram, external beam radiation, laparotomy. Duodenal is not. Pancreatic carcinoma is there. So there is hepatic angiostomy. Percutaneous transhepatic drain. '82-year-old lady is often taken to theatre for common bile duct stone exploration. So CBD exploration is to be done, and stone is impacted the distal aspect of the common bile duct. Distal aspect of common bile duct. She has stone impacted on. Despite best effort, it proves impossible to remove it. The stone is impacted the distal aspect of common bile duct and despite of close the bile duct and tube, undertake choledochoduodenostomy, arrange the repeat ERCP, construct hepatic duodenostomy. T-tube possible, choledochoduodenostomy. Okay. 43 are admitted with acute cholecystitis and failed to settle. Laparoscopic cholecystectomy is performed. At operation, gallbladder is evidence of empyema and calostring and informed surgeon assistant. Mary Z, what is the best course of action? Laparotomy open. Repeat episodes of abdominal pain and small bowel obstruction, laparoscopy surgery was to identify and most common appropriate. Leave the gallbladder in situ. "43 lady present with jaundice and diagnosed with carcinoma of the head of the pancreas, deeply jaundiced, staging in negative for meds. What is the best biliary decompression? ERCPT, stenting has to be put. Placement of the stent. 43 lady with colicky abdominal pain and own exemption, mixed pyrexia. Ultrasound shows gallstone that is patient is taken by theatre, open cholesterol and operation cholesterol. Impossible. What is most likely explanation? Bile carcinoma, Merici syndrome. "55-year-old has a jaundice and temperature is 39. Known to have gallstone. Blood culture has shown gram-negative bacilli and large bile duct measuring 1.2 centimeter in diameter. ERCP instant. "43-year-old lady presents with attacks of acute pancreatitis. Classified mild attack pancreatitis imaging shows gallstones but normal caliber. Peri-pancreatic fluid collection and what is the initial management? Nasogastric cholecystitis once attack has settled. "34-year-old lady is admitted with jaundice and undergoes ERCP. The procedure is technically difficult and she is returned to the ward still jaundiced. Unfortunately, she has several general abdomen. What is best course? ERCP is failed. It means patient needs CT scan. The 63-year-old man obstructive jaundice, 63-year obstructive jaundice developed past 3 weeks. Well examined and smooth mass in the right upper quadrant. Malignancy, pancreas. "73-year-old distal gastrectomy for carcinoma of the stomach with jaundice. Ultrasound liver shows no focal and normal caliber bile duct and hepatic condition. Gilbert syndrome, very high lymphadenopathy. 22-year teacher is admitted with severe epigastric pain, serum amyloidosis, We wish to perform perforately viscous determine pancreatic prism. Order X-ray and plain film. Perforated viscous plain film X-ray or CT. Request CT scan.